Hello there, I'm Tony Meekum. This is topic 12, multifocal radiolucencies. Now we've been through several topics. I'm going to start kind of speeding up with how I present this. So have your study guide and chart handy. All right, and here's our outline. So wouldn't do justice if I talked about multifocal radiolucency and didn't mention seminoosseous dysplasia, potential periapical radiolucencies, but we've already covered those pretty extensively. As well as dentin dysplasia, we haven't covered that yet, but we're going to teach that subsequently in our tooth abnormalities lecture. And we also talked about metastases. So we're going to focus on these ones. Basal cell nevus, cherubism, neurofibromatosis. And those are our well-corticated lesions. Very benign, very well corticated. These ones look well defined, but are not corticated. And so this is a little tricky because we usually think of well-defined lesions as being benign. But in this case, in the case of multiple myeloma, Langerhans cell histiocytosis, those are well-defined, but they're mostly non-corticated, kind of our punched-out lesions. And those I consider malignancies. There is a benign version of Langerhans, but I go ahead and lump it with malignancies. Same as metastases. Usually those are going to be ill-defined, but in some cases you get these multifocal, well-defined entities that are just metastases of some other tumor. And when you're thinking of Langerhans, also consider this: leukemia, lymphoma. When we're talking about multifocal radiolucencies, those can definitely cause that. So any hematopoietic malignancy can do that. In fact, I lump these L's together. I call them the 3 L's of malignancy because they kind of behave similarly in a lot of cases. So let's get to the first one, basal cell nevus, also called nevoid basal cell carcinoma syndrome or Gorlin-Goetz. This is an autosomal dominant variable expressivity syndrome. And here's the one thing you need to know, because this is the highest yield fact in this lecture. Basal cell nevus causes multiple OKCs, odontogenic keratocysts, not ameloblastomas, not giant cell lesions, multiple OKCs. So if you remember one sentence from today, that's it. The rest of the syndrome, think of multiple basal cell carcinomas of the skin. That's where it gets its name. Palmar and plantar pits, calcified falx cerebri, enlarged head circumference, rib anomalies, including bifid ribs, and hypertelorism. It typically appears in young people and children, although it can occur anywhere from 5 to 50. So earlier onset than solitary OKCs, and with a higher recurrence rate. So these patients have to be followed consistently throughout their life to see if they develop new OKCs. All right, imaging is simple. Everything you learned about solitary OKC, but multiple locations, and often bilateral. Plus that calcified falx cerebri showing up early in life. All right, imaging features, pretty simple to cover here. All the same as your solitary OKCs, but now multiple. They can be bilateral. Also calcification of the falx cerebri, which we're not going to see in most of our imaging, maybe on occasion on CBCTs. And so if you saw this image right here, hopefully you could identify there are these multiple, well-defined. They look like odontogenic right around the roots of teeth, but they're not necessarily periapical lesions. This is a case of basal cell nevoid syndrome. This is another case. I've said this before, but I think I find myself a lot of times when I look at a panel, the first thing I do is kind of guess the patient's age. Well, the third molar's crown's still forming. The second molar's not yet erupted. Some of the premolars not yet erupted. This patient's around 12, and we've got at least one well-defined lesion here. What's this? The third molar's way impacted up into the sinus. Just seeing that could be a dentigerous cyst. Then you notice that there are multiple lesions, and this is a case of basal cell nevoid. Here we see in the axial slice, well-defined, corticated, and maybe we didn't appreciate that in the pano, but now we see it better in the axial CT slice. All right, so as far as differential, think maybe multiple myeloma, but those lesions are not corticated. I would say that for the most part, they're not corticated. Cherubism, we'll talk about that next. That's younger patients, more expansile, and it pushes the teeth anteriorly. We'll show you examples of that. Dentigerous cyst. Someone could have a bilateral dentigerous cyst, but that's pretty rare, so look for that CEJ attachment. But if you do see two dentigerous cysts, you should definitely think about this syndrome and maybe rule it out. And management matters here. Treat like OKCs, which have to be treated a little bit more aggressively than a lot of cysts, even some benign tumors. But this one even more aggressively. Now we're talking about the syndrome. So yearly CT surveillance, consider referring for genetic counseling. As we talked about all the different parts of the body that it affects, this is a diagnosis with consequences for the whole patient, not just the jaw. So based on information I just said, can you diagnose this? We said OKCs. We saw examples where it pushed the teeth way backwards, but if something's originating from behind and pushing the teeth forward, even younger onset than basal cell nevoid, this is cherubism. And instead of multiple OKCs, this is multiple giant cell tumors. Difference with your solitary CGCG is these tend to originate more posterior. And so maybe you saw those signs. This patient's younger than 5, which we said basal cell nevoid starts to tend to occur around 5 and older. But this is a very young patient and teeth pushed forward. All right, so having shown you that case, let's talk about cherubism a little bit more. The C of our BC anachronism. This is a rare inherited condition causing bilateral enlargement of the jaws. Histologically, these are giant cell granulomas, which is a nice callback to our MACHO acronym. It occurs in early childhood, 2 to 6, so usually a little bit earlier than basal cell nevoid, although of course there could be overlap there. Painless bilateral swelling. It gets its name because with this jaw swelling, both the mandible and the maxilla, it causes this kind of upward appearance tilting of the eyes, which makes them look like these old paintings of cherubs. And so what are these lesions going to look like? It should have that granular bone, maybe wispy septa, exactly like we described CG, other than what? The location. So now they're in the posterior. Hopefully you can answer this now. Both are inherited conditions. Both give you multiple well-defined corticated jaw lesions as a child. But think about 3 things. Age, which one's younger? Cherubism, younger, around 2 to 6 versus 5 and up for Gorlin. Symmetry, cherubism is strikingly symmetric. I don't think I mentioned that. And bilateral. But that's what we saw in all those examples. It started back here and pushed the teeth forward. And that's another differentiator, the fact that it pushes the teeth forward, whereas OKCs, or for basal cell nevoid, those OKCs can occur anywhere throughout the jaw and push them really in any direction. And then what about histology? Hopefully you remember basal cell nevoid, OKCs, cherubism, giant cell lesions. Having said that and shown you examples, this looks like the same example I showed you at first, but multiple bilateral, posterior, well-defined, corticated tumors pushing the teeth anteriorly. This is your classic cherubism. What about this one? Is this cherubism? Well, there's one tooth kind of being pushed down, maybe this one a little bit anteriorly, but then you have lesions arising here between the first molar and premolar. Multiple cases, not quite as symmetric. How old is this patient? This is an older one. This is an adult. And so this is a case of basal cell nevoid. So hopefully with that kind of brief introduction, you can differentiate between the two. Oh, one more example here. What about this one? It's nice and symmetric. We see it in both sides of the mandible, but look at where it's pushing the teeth. This one pushing the developing second molars, it is actually pushing them posteriorly. That's more your OKC, and we also have something here developing around the premolar crown. And so this is another case of BCN, basal cell nevoid. All right, and now on to the N of our BCN acronym, neurofibromatosis, or called von Recklinghausen disease. This causes cafe au lait spots, which is not what you see here in this image. Those are smooth, pigmented, but unraised lesions on the skin. But you also see, what we're seeing here is peripheral nerve tumors. These patients can have multiple of these, like you see here. Various other dysplastic abnormalities. Neurofibrosis 1 is the generalized form. It's the one with oral lesions. Neurofibromatosis 2 is central, and you're not going to see those oral lesions that we're going to talk about now. And so with NF1, neurofibromatosis 1, they can have multiple either neurofibromas, which is where it gets its name, or schwannomas could be present as well. Typically how this presents is, expanding from the nerve canal as you would expect from a benign nerve tumor. But other findings that you're going to see in the mandible specifically is an enlarged coronoid notch, obtuse angle between the body and the ramus, a deformed condylar head, lengthened condylar neck, and lateral bowing and thinning of the ramus. That one you're going to appreciate in either a CT or in an AP cephalometric image. But the one really to remember, because it makes the most sense with this disease, is enlargement of the mandibular canal and the mental and mandibular foramen. Tumors are growing on the nerve, so the nerve's tunnel gets bigger. It's one of those images that looks like a snake that swallowed a rat. Also, erosive changes on the outer mandible and interferences with molar eruption. Differential is other things in this lecture, other multifocal diseases, basal cell nevus, metastases, multiple myeloma. Management, it'd be difficult to manage all these lesions, but they are benign, and so you're probably just going to excise the painful ones. Here's some examples. You see this multifocal radiolucency appearance? In this case, it's not quite as well corticated like we saw with the basal cell nevus. We see uneruption, we see actually inferior displacement of these teeth. We also see back here, and what did I say about changes of the mandible? You see an enlargement, kind of a deepening of this left coronoid notch. You see this more obtuse angle where it's almost more of a straight line between the ramus and the mandibular body. And then this lesion here is actually enlargement of the mandibular canal. So all these little subtle signs of the mandible that you might appreciate with neurofibromatosis. And then here's something you may appreciate in a CBCT, or in this case a CT, or if you have a basal skull view, you can see outward bowing of the ramus in the lateral direction. I have seen this as well in lateral cephs. You can kind of see the outward bowing, but that's another feature of neurofibromatosis. All right, now getting into the non-corticated malignant group, the MLM. If you are from Utah, then MLM kind of has a bad name around here. And so it kind of goes with these lesions that could be somewhat foreboding. Starting with multiple myeloma, a systemic malignancy of plasma cells. A single lesion is called a plasmacytoma, But if they have them in multiple locations, that's multiple myeloma. Ages 35 to 70, males more than females. Clinically, this can cause fatigue, weight loss, bone pain, anemia. A lot of these bone or hematopoietic malignancies can do similar things. Posterior mandible more often than the maxilla. And then the radiographic term you really need to know is punched out. If I say punched out, this should be the first thing that comes to mind. Here's a piece of paper with these punched out holes. And that's kind of what you're seeing all throughout the mandible. They talk about these as well-defined but non-corticated. If you look really close, I think some of them do appear to have a cortex. And that's going to be the case with multiple myeloma or Langerhans cell histiocytosis. But just seeing multiple of these and a lot of them non-corticated, go with that punched out description and start thinking multiple myeloma. Sometimes these can appear more malignant where they're ragged and infiltrative. Sometimes the bone overall just looks more radiolucent, that osteopenic appearance. It resorbs cortices. Rarely is it going to resorb roots though. And so how do you know, just looking at this, why aren't we thinking benign things? Well, keep in mind, you see multiple punched out areas, start thinking these type of malignancies that we're going to talk about. You see multiple lesions in general. If it's not that classic basal cell nevoid or neurofibromatosis or cherubism, then start thinking more of malignancy, maybe a hematopoietic thing, something that's affecting the blood, affecting the bone. All right, differential. Metastatic carcinoma, we're going to talk about Mets a little bit. We've already talked about that. And of course, for those, you separate them by a history of prior malignancy. Severe osteomyelitis, but there should be a source of infection in most cases, although sometimes it's bloodborne and unknown. And inflammation causes sclerosis in most cases. I talk about osteomyelitis being a mix of sclerosis and radiolucency, while myeloma doesn't do that. And then generalized radiolucency from any of these systemic conditions. Maybe the first one I talk about it a lot is hyperparathyroidism. So for that, you could check the calcium and PTH levels, but we'll get to that in another lecture. For now, let's go on to Langerhans cell histiocytosis. So this is one of the 3 L's, and I said, think of these 3 L's together. Whenever you see one or think about one, consider the other 3. And that's Langerhans, leukemia, lymphoma. When I talked about tooth displacement as usually being a benign sign, I said other than one direction, if a tooth is displaced occlusally, think maybe one of these 3 L's of malignancy, Langerhans, leukemia, or lymphoma. And these can have that multifocal appearance, sometimes even well-defined. Leukemia specifically in young children, it can form in the apices of teeth and really just look like periapical lesions. But let's focus on Langerhans for a second. There is a non-malignant form, an eosinophilic granuloma, or a malignant form. But again, I just kind of, in my mind, I lump these all together with malignancies. And in these cases, a lot of times they'll appear punched out, but sometimes they do appear corticated. The key thing here is this scooped out appearance. Does this look like typical periodontal disease? Periodontal disease starts from the top down, and it usually doesn't undercut the bone like we see here. That's a classic sign of Langerhans cell histiocytosis. We can see here in this case, maybe they just assumed it was periodontal disease and treated like periodontal disease, but then a year later, now it's looking a lot more aggressive. It's looking a lot more like a malignancy, right? This is a disease of youth. It occurs in older children to young adults, and can cause other clinical signs, dull pain, bony, soft tissue swelling, bleeding, ulceration. And so I already kind of described the imaging here, but it's moderately well-defined, non-corticated, punched out. But just like with multiple myeloma, a lot of times it looks like you can see a little bit of a cortex as well. So don't be deceived by these. Whenever you see these multifocal lesions, really come back to this lecture, come back to this differential and think, okay, could it be one of these other things that might be malignancy or metastasis? And Langerhans can stimulate periosteal bone formation, just like infection. And so I said, you see that periosteal bone formation, particularly the onion skin one. Think Shrek, think osteomyelitis, but keep in the back of your mind, it could be one of these other things, and Langerhans is one of those that can do that. So here we have these punched out lesions. Again, if you look closely, I would say some of these even look corticated, but this multifocal appearance, just seeing this appearance alone, I would think one of these 2 things, Langerhans or multiple myeloma, it can do that in the skull as well. Then let's look at these in the jaws. Young patient, looks like potential periapical infection, but no real deep caries lesion or anything going on with these teeth. But we see this periosteal reaction. So you're starting to think, well, it looks like infection. But if this were an infection, it would be very severe with no known source. And so keep that in mind. You see periosteal reaction. You don't really see a source of infection. Think, could it be Langerhans? Here's one in the mandibular condylar neck. Again, we see that periosteal reaction. We see the same thing in an axial slice now, and really the periosteal reaction stands out. And just looking at this, I would say 99% of the time that's going to be infection. But you look at the rest of it, and there's no known cause. There's this kind of this punched out lesion, similar to what we see in the jaws, where is scooped out in appearance, that's more of a Langerhans. And so you've got to be able to distinguish this from periodontal disease. You don't want to be someone that misses this just assuming it's an aggressive periodontal disease. And so pay attention. Periodontal disease starting at the crest of bone. It doesn't undercut bone. It doesn't, when we're describing soft tissue lesions, we kind of call that pedunculated, right? Versus sessile. PD, periodontal disease, would be a lot more sessile, where it just starts at the tooth. Sometimes it's really angled against a tooth, but it never just scoops underneath the tooth. Maybe if you had a periapical inflammatory lesion, it can start to grow, and that could look similar to a Langerhans. But Langerhans tends to form at the midroot level as well, instead of right around the apices of teeth. Squamous cell carcinoma, other malignancies, they may be indistinguishable. Sometimes Langerhans is going to look like we saw in that example a year later, where it looked more ill-defined and invasive, but in a lot of cases, Langerhans is better defined. Younger age group as well. Periosteal reaction, all those favor Langerhans. And what's the big term to remember? Scooped out. That scooped out appearance is classic Langerhans. All right, I have mentioned metastases, so let's go real quick here. Notice how in some cases this can be really deceptive. Metastases, same with leukemia, although probably younger patient. This just looks like a periapical lesion. They have a sizable occlusal restoration. No reason to think that's not a periapical lesion, but if you vitality test this tooth and it tests vital, be wary, maybe compare with the patient history. This was a woman with a history of breast cancer. And so this is again one of those cases where history can tell you a lot. And so we got to be more wary when a patient has one of these metastases that tends to expand to bone. And I think I've mentioned that before, but the BLT kosher pickle, breast, lung, thyroid, kidney, prostate. So that covers our two gender-specific one, the breast and prostate, which in the last lecture I talked about how those can lay down bone. Those can cause a sclerotic appearance and even the sunray appearance, but they can look just like any other metastasis and just look radiolucent and invasive. Here we have a 64-year-old man with a previous prostate carcinoma. This one looks a lot more aggressive than just your typical periapical inflammatory lesion. You might start thinking inflammatory, and I've shown you examples of acute inflammation where it can be like this, but look how destructive, look how extensive this is. All the way through the mandible, really ragged borders. I said malignancies like to do that irregular PDL space widening, so a lot of signs of malignancy here, and his history might tell you that he's at a risk of that prostate cancer metastasis. All right, this was a case that I don't really have the answer for, but it looks like one of these things we've talked about. Looks like potential multiple myeloma, potential Langerhans, although this patient's a little bit older for Langerhans, right? So I think maybe myeloma or metastatic disease. If they had a history of one of those BLT kosher pickle cancers, then it's likely that recurrence, but something's going on that's not good in this patient. It's more than just typical periapical lesion or periodontal disease. And this was a carcinoma, not sure what type. It could be a lung carcinoma metastasizing to the jaws. Look at the widened PDL space. Look at that sign. It comes up over and over again. The irregular PDL space widening, along with a little bit of a destructive, ill-defined lesion throughout the mandible. All right, now going on to our cases where you can test yourself. What does this look like? Is this a solitary lesion or multifocal? Hopefully you appreciate that huge one there, but then also one up here in the maxilla, causing an impaction of this canine, superior displacement, and also one here on the left mandible, and it's displacing the canal posteriorly. You can see that nice, well-defined corticated border. The canal border remains intact. One other thing I'll point out before we get to the differential, we can pretty much diagnose it from this, right? It's never a final diagnosis, but I can pretty much tell what this is. But look at the expansion of this, the expansion pattern. It does look like a multilocular lesion, so we got our macho acronym. Is this more ameloblastoma or OKC? Well, look at the expansion up the mandible, kind of that banana-shaped expansion where it's really following the length of bone with relative little either buccal lingual, in this case we can appreciate more the superior-inferior expansion, and that's more your OKC than it is ameloblastoma. So this is likely multiple OKCs. This is basal cell nevoid syndrome, pretty much a diagnosis based on the radiograph. Hopefully you got that one. All right, how about in this case? Here we've got this lesion. Ooh, it's in the ramus of the mandible. It's well defined. It's pushing this tooth anteriorly. That might make you think one thing, but what's the age of the patient? Well, the roots of the third molar are still developing, but this patient's older than your typical 5-6-year-old. We see a baby canine here, but that's because the adult canine is impacted. What else do we see? Look where the asterisks are. You see these well-defined corticated lesions displacing some teeth posteriorly and superiorly. And so that's not typical for cherubism if that's the first thing you thought just looking at the location of this. This is, again, basal cell nevoid. And I'm not going to talk about histology that much again, but that's classic histology for an OKC. All right, how about in this case? Looks like a lot of teeth are missing. It looks like these teeth are underdeveloped. Not really sure what's going on with the dentition, but this is an 8-year-old boy. Had this going on for a while. It is very bilateral, pushing these teeth anteriorly. And now this is a case of cherubism. Bilateral, symmetry, posterior expansile, young patient, very young when this onset. And so that's your classic cherubism. All right, last one here. What's your differential? You have multiple well-defined, I would argue some of it's corticated, but a lot of them appear non-corticated lesions. So keep that in mind. I kept mentioning how these are described as non-corticated, but when I look close, I think I see some cortication. But for these multifocal lesions, what are those ones we mentioned that do that? Multiple myeloma, Langerhans. Could this be metastasis? Sure. Osteomyelitis? Nah, not really. It doesn't look inflammatory. There's no sclerosis, no periosteal reaction. All right, so how'd you get there? You didn't memorize a picture. We have this list, and hopefully these acronyms are helping. You asked whether these lesions were corticated or non-corticated, and me having described that some of them appear corticated, but that happens with your MLM lesions. So that should get you to that MLM acronym. Multiple myeloma, Langerhans, and metastases. So hopefully you feel like that's helping. Hopefully this is starting to come together and these acronyms are getting you to the correct differential. But that's it for multifocal radiolucencies. Corticated means syndrome, and that's basal cell nevoid. And that acronym is BCN. It just happens to be the same acronym for basal cell nevoid. So you can go off of that, but basal cell nevoid, cherubism, neurofibromatosis, and then non-corticated, where it looks more potentially malignant, even though some of them look a little bit corticated. Think your MLM acronym. So multiple myeloma, Langerhans, and metastases. All right. See you on the next one, multifocal radiopacities. Thanks.